Up next, we have our prostate cancer keynote with Dr. Samuel Washington. He is an assistant professor in urology at San Francisco VA Medical Center and University of California, San Francisco. He completed his medical school training at University of California, San Francisco, and was selected by the Department of Urology to complete his urology residency. He stayed on at UCSF to complete his oncology fellowship, during which time he finished a master's degree in clinical research. His research has focused on prostate cancer outcomes, with current research focusing on health services and cancer outcome disparities with genital urinary malignancies. His ongoing research efforts continue to mirror his passion to expand our depth of knowledge in medicine and how variations in care at the local level drive differences in treatment and survival for patients with cancers. By understanding local variations in treatment, we can better inform and understand barriers to change at the provider, facility, and healthcare systems level to improve outcomes in genital urinary cancers. Please welcome Dr. Samuel Washington.
Hi, everyone. Can you hear me?
We can hear you.
Perfect. It says I can't start video, but I can at least show my slides. Let me go ahead and just change my slides. Here we go. Are you able to see my slides here? Sorry, I'm hopping in between clinic and this. So let me see if the video works now.
We appreciate you.
Right? Okay, perfect.
We can see, yes.
Excellent. I'm Sam Washington. So I'm a urologic oncologist. So I'm one of the people that treat, work up, evaluate people for prostate cancer. And, you know, I think over time, people have understood that there are disparities in prostate cancer. We all know that. And I think everyone, you know, in my field just kind of stopped at the observation. So I'll apologize up front for being pretty critical of my own field and my own colleagues, but I think it's important that we go over this. So I'll just touch upon kind of background for Black men with prostate cancer, a few definitions and how we use them incorrectly in the research that we do within urology, ways that we really should be thinking about this and others do outside of our field. And I think that's part of the problem. And then just conclusions for this. So Black men in medicine and prostate cancer. So overall, we know the burden of prostate cancer. And this year, about 268,000 new cancer cases. For African-American men, that'll represent about 37% of all the cancer diagnoses this year. Still remains the second most common cause of cancer deaths for Black men and everyone in the United States. Now, we've known that there's been a consistent disproportionate burden in terms of death, in terms of delays of care, earlier onset. And although we've seen reductions, that benefit has not been the same that we've seen in other groups. Now, this is where we start to break down as a field and how we look at this. Science, medicine always defer to biology and kind of report decreased rates of screening, report earlier onset of disease, diagnosis at later stages or more advanced disease and worse care, but it doesn't factor into how we examine this, and that's been largely the problem. So I just want to go over a few definitions. So disparities, just differences. It's strictly is just math. There's a difference between two groups. You have disparities, left-handed compared to right-handed people, Pepsi versus Coke fans. Racial disparities in prostate cancer survival is the one that's most relevant for here. But we've largely stopped at the why. We understand that it exists, but our field has not moved beyond that. And for that, we really need to understand how we're looking at all of these things. So we've always talked about access to care in all of the disparities papers on prostate cancer, talked about treatment and survival, but they've always removed context. So they kind of focus everything on the patient. And we've learned from the last 30, 40 years that that doesn't buy us much. And really context is key. And that's when we have to take a step back and understand how patient level cancer characteristics that I talk to patients with in clinic are impacted by the healthcare system, health policy, residential zoning, where you live in the country and the type of care you're receiving, and then also the laws and policies that have impacted care. So that context has been the thing that has been missing from all of the urologists like me doing this type of research. So context really lets us understand the how. And then I just want to define social determinants of health. We've always used it to describe the patient and the patient's income or the patient's education. But the CDC and the World Health Organization define this as conditions in which people are born, live, work, and age. These are circumstances outside of the patient. And that always seems to be lost in translation when we talk about prostate cancer disparities, particularly in my own field when people publish on this. Just recently, I was on a section study looking at grants, and people were focused on social determinants of health and only looking at people's tax bracket. And I'm like, that misses the point entirely. But that is just, we aren't even at the point where we're routinely using the definitions we should be to examine this problem. Now, I want to just hop on race as it's used currently. In research, people always try to use it as a proxy for biology, but we know that it's more than that. There are other impacts associated with race that go along with all of the observations and outcomes that we're seeing that do not have any impact on biology. But again, we always try to go to race being a biologic construct and ignore how society has defined race and how that social construct or that social definition impacts who you're going to see, the type of treatment you're going to get, if you're going to get treatment, all of these things. So actually, some basic scientists about 5 years ago in Science, one of our large magazines, said race is a social construct. And they agreed that getting a database, looking at black-white comparisons, and saying that any differences you see are based on biology is not the appropriate way to do this research, but it's the most prevalent way that continues to be out there. It's the most pervasive way that we have. And they acknowledge that this is a weak proxy for genetic differences, even though we always want it to be. And there's been a long-standing concern about how medicine has used race to justify differences that are largely dependent on political and society level factors. So that's really where our research needs to be. And that's why you'll hear a small section of us within urology talking about this, because how we look at this needs to change from a research side. Now, all of the disparities work you see uses databases, large collections of information from any number of different sources. The problem is how race is collected. Everyone wants to put out a paper that says disparities and compares black and white race. But you can see here just from this graph that many of the common databases that people are using, not even sure if race is validated. A lot of times only 3 to 5% of the patients in that cohort, in that data set, are even Black or African American. You don't know if that's what people said that they were. You don't know if that was assigned by some person behind a desk, just based on the way this person looks. You have no information. So the data we're using is, for lack of a better term, trash coming in. You're only going to get trash coming out. And that's one of the problems that we have. The other is that we call everyone else other. So we don't have good characterization to start out with. So when we talk about how can we use data to move things forward, well, first we need to figure out how can we get better data. And that brings me to what everyone, I assume, is hearing about now, is how do we improve representation for clinical trials? We know the population of African American Black people within the United States is, compared to clinical trials, is horrific. Everyone has understood that, but it took really regulatory or kind of rule setting for people to actually act upon that. And that's kind of ridiculous. We know that for prostate cancer, this is where people are getting opportunities to have new drugs for advanced cancer, for bad disease. This is where people can get those new drugs to see if there's a benefit. We know out of 72 clinical trials, only 6.7% were Black. We know out of those seven trials where they have new drugs, only 3.2%. So out of 7,200 men, nearly 7,300 men, only 150 actually got the study drug. And the problem is they're going to use that 150 men and then try to extrapolate to all of us in terms of how this medicine may work. And you can already see the problem with that, but it seems like we're the only ones seeing this problem. And others are just kind of chasing numbers, right? So we know that in our data sets, we're not characterizing people well. We know that these people are missing. They're nowhere near the representation that we have relative to the general population. But we seem to be in this cycle of just, let's try the same thing with slightly newer technology and hope for a different outcome. Then when we move past race, other people will say, okay, well, let's isolate insurance and see how that works. But all of our other measures aren't great as well. We talk about race and ethnicity, but it's really societal factors, social construct, and genetic ancestry. We talk about insurance, but that's really insurance coverage and then your out-of-pocket costs. We talk about education, but we're really trying to get at how much people understand our medical jargon, how far they got in school. We talk about employment status, but it depends on the type of job you have, your salary, changes in work status over time. We talk about income, but that's really flexibility. If you get sick, can you pay for the treatments? Do you have assets or money that could help you pay for medications? We talk about comorbidities, but we're really trying to talk about medical frailty. We talk about access to care in all these data sets, but they're in the data set. So by definition, they've gotten access to care. And again, we're using that as a poor proxy, a poor measure, substitute for the quality that they're getting. So the measures we're using right now are not great. And we keep trying to force them to replace things that they shouldn't be, when really we should be reevaluating how we're doing this all together. And this is where thinking about disparities is not just kind of a black and white standard approach where we adjust for everything, we take everything into account, but we restrict everything to one factor, just race or just insurance. That's not how the world works, right? I wouldn't describe myself as a Black. I'd say I'm a Black male physician, father, gardener. There are multiple layers, and all of those layers impact how I'm going to interact with the healthcare system, how I'm going to interact with people here. So the way we're setting up research is not designed to get solutions, because we're examining things outside of the natural process and natural way that things exist. And oftentimes, if you look at urologists doing research, when we start to look at, okay, practice patterns, that's where things get a little bit too close for comfort. That's where we start saying, well, if we look at how our own patients are being treated, we may see something that makes us uncomfortable. So when we start talking about disparities in urology groups, everyone will say, I am not contributing to disparities. But when I ask them, okay, have you looked at your own data? That's when I hear the crickets. And that's actually where we need to be. We need to start examining all these other levels and stop focusing just on the patient and assign blame to patients for systems, practice, physician, institution, state level issues. So all of these levels play into the problems we're seeing, but our research has really only been focused on the patient and on the individual, which is the reason why we can have the next newest high-tech genomic study, high-tech basic science research, and we will always miss the bigger picture because we're not looking for it. Now, a more comprehensive approach to looking at disparities is stuff that's happening now outside of my field. These are people who are looking at, if you're in Texas, where I grew up, or California, where I work now, how's your care going to change, even if you're the same person with the same cancer? Or if you're in the same healthcare system, if you're in the VA, how's your care going to change at one site, VA site, versus the other? Because they always talk about the VA being equal access, but we know that that's not the case. Equal insurance, yes. Access, no. And when we start to drill things down, we start to get uncomfortable and evaluate the systems in which I work, the systems in which we exist and interact with, that's when you start finding things above the patient that can be targets for intervention and change. That's where you start getting insight from people and how they interact with all of these barriers, these structural problems that have been there, that have been our blind spot, so we can understand what needs to change. But first, we have to acknowledge that there is a healthcare system problem. And I think intuitively, we always understand that, but we always think that we're not part of that. And I think having to accept that we're part of that, and we have to look at that and understand where the problems are, they're not all with the patient. Once we take that step, I think we'll get towards how can we make change at a systems level, at an organization level, or even within a practice. How could I change my practice and the practice here so we move towards better outcomes? And this is really where we're at overall. We don't know much. We understand that there are problems. We've been observing problems for the last 30 years. We understand that there are differences based on race. We understand that that's associated with differences in income and education and outcomes and how people are treated, but that's largely where it stopped. People now are focusing on clinical trials. How can we get more patients into clinical trials? I'd like to make sure my patients don't need a clinical trial. So I try to, how can I get patients in to see me earlier so I can diagnose and treat prostate cancer before it's moved outside the prostate, before they need a clinical trial? How can we start changing our systems to make it easier for men, Black men, to be evaluated for prostate cancer and treated appropriately? And how can we monitor things? So if people are saying, I'm fine, my practice, there are no problems, we can actually look at their practice and see if there are problems, because we are not the best policemen for ourselves. There need to be different structures in place for this. People talk about race-based differences in how people respond to medicines. How can you do that when it's only 3% of the whole group? It's just ways that don't make sense, but they're comfortable ways, and they're ways that assign things to the patient and ignore how this system works. So I'd say overall, when it comes to improving prostate cancer outcomes, if we were doing it right, it would have been done already. People were interested in it, it would have been done already. And I think there are a lot of us interested in it, but we're not the people designing the research questions. We're not the people on the study sections giving grant funding to the projects that are doing this correctly, the projects that are doing this right. It's largely the people who are not in this space, who don't have any idea of what's going on or context or disparities other than just black and white comparisons, who are saying, oh, this project, which is the same as the others that have been the last 20 years, looks good. This will crack the code of the biologic differences based on race for prostate cancer outcomes. We need more research that's focused on what's important to the patients and understand and integrate our knowledge of these barriers so we can understand what aspect is truly societal versus biology versus practice level, how I work. When it comes to clinical trial participation, we actually need evidence to understand which treatments work better. And that means we need patients involved. We need populations in the trials that look like the populations I see in clinic and look like the US population. That means there need to be structural changes to improve access to clinical trials. There needs to be better ways to improve care and quality. One way to do that is a clinical trial because everything's heavily monitored. There's an investment being made to a clinical trial. People want everyone to have the best care possible. It's just that that falls off outside of that strict monitored setting, unfortunately. So I say overall, again, I'm fairly critical of our own field. We know some stuff, but I'd say we don't know enough. We do not know enough. We know there are problems, but that's largely where it stops in urology. We need more input from people outside of the usual group who are deciding what research gets funded, who decide how treatments and outcomes are framed, how disparities are demonstrated in research, and how they're investigated with studies. Those answers that we need to push things forward will come from outside of your usual bubbles. Our standard has been us in the ivory tower, get a data set, compare two groups in isolation with no context. We see it, we publish it, and then we go on about our day. That can't be the standard anymore if we expect there to be change. So sorry, I think I took dramatically less time than my 20 minutes, but there we go.
Thank you. We actually have a few questions in the chat and
Okay, there I am.
oh, Nikki's got it. Thank you.
Yeah, I'm here. I'm here. Had to turn the mic on. You would think I'd know how to turn a mic on after after all these years. But thank you so much. Thank you so much, Dr. Washington. We have plenty of questions here. I'm just going to jump in and throw these questions at you. What can we do to help ensure Black folks are included in the trials and the research?
I think that it's a tough question. I'd say that, so what I know of UCSF, for example, you have to hold places accountable. So we are looking at how our catchment area, so the population we treat, how close that looks to the population in our studies. And right now you're starting to see government institutions and funders start to require that. And that's really, once you start taking away people's money because they're not doing the right thing, people hop on board pretty quick. But I think that means you have to start holding people accountable. I wish I could do that. I'm very junior. I don't have any grays yet. Once I have a couple more grays, hopefully I can start pushing these things myself. But I think once you start holding institutions accountable, you'll see a lot more recruitment. You'll see more community engagement earlier. And those are the things that I think people can do. For patients who are being seen, always asking, are there clinical trials I could be a part of? Understanding, are there institutions like UCSF or others that are doing clinical trials? And you can sometimes see online what resources may be available, because I don't think we can honestly rely on the systems themselves to give us the best options. As negative as that sounds, sorry.
Wow. And what brought you into this work?
Can you hear me? Oh, did it freeze?
Yeah, I can hear you.
Oh, okay. Oh, I was worried it froze. Sorry.
Did you question? Or maybe
Nikki, you're going in and out a little bit. Can you repeat the question?
Okay, so the sound is not. Okay. What brought you into this work?
Well, I grew up in Texas.
Can you hear me?
Yeah, can you hear me? Perfect. Well, I grew up, I was always interested in cancer.
Yeah, I can hear you now.
Okay, perfect. I was always interested in cancer. And I grew up in a different part of this country in Texas, which sometimes they think they're their own country. But I realized just how different things were when I moved from Texas to California. And you start to see in the hospital how different care is based on things that have nothing to do with the disease. And that's really what led me to this type of work. But I needed to do it better than we've been doing for the last 30 years. So that's why I had to do the master's and do that through residency and then my fellowship training. So I can learn from people who are doing this outside of urology and doing it well and understand how they do it and bring that into urology. So that's my goal, you know, because we do not get trained of how to do any of this research well. We just get trained on how to pay statisticians to tell us what to write.
Yeah, I'm sure there's a lot of people, you know, who is in the group right now who can identify with what you just said about, because I'm from, you know, Louisiana.
Yeah.
And coming from the deep South and coming to California is always an eye-opening experience. Direction is always a very eye-opening experience. So another question, what's happening with Black men in the Bay Area relative to prostate cancer? Is there more awareness? Are Black men taking care of themselves better? Can you speak on this a little bit?
I think here there's a concerted effort to do better. And I can't say that that's present everywhere in the country. So I'd say that here there are real partnerships happening between UCSF and the community. Not UCSF starting a study and then going out and trying to find things, but really giving people a voice as best as we can. And I think it's created a paradigm that other places are trying to replicate. So I think here there are opportunities for men to get more information, to see urologists and doctors that look like them. Opportunities to understand from one another this whole process, opportunities to get screening. There can always be more, and there should be more, But I think there's enough people like Dr. Rhodes and others at UCSF who are doing this work and pushing things forward. And thankfully, those are all people I can learn from as a junior faculty member.
Okay, wonderful. All right, what do we do next? Now that we have the data, what actions have you seen on the provider side to address these systemic issues?
So I think it's varied. I say all of us, every meeting I'm at, there's something now on health equity or disparities. Everyone asks, what do we do for it? And I would say, well, we don't even know where it's worse and where it's better. So that's like me trying to say, how do I make Target better? Right? Or how do I make Walmart better or Costco better? Well, I mean, every business would go and look at which store is doing better, which one's doing worse, understand what's working well, what's not, and fix the one that's not doing well. That's not the approach we've taken. Our research has largely just been across the country, there's a problem, and we stop there. And that doesn't really provide us with data to do interventions, right? Because we don't really look at our own practice, and that's our black box, that's our blind spot.
Yeah.
So oftentimes I tell people, you have to start looking at how things are happening around you, and that's where you can start. But that's not always as exciting. Or, you know, it can be triggering for some people to hear that. We'll put it that way.
Yeah, that's a whole nother can of worms.
Yeah.
We started off our first session talking about that. So another audience question, can you speak to some of your own research, maybe your most critical study?
Yeah, I mean, so I've really focused on, okay, based on who you are and the type of cancer you have, how is your treatment going to change? So previously, there was a study showing that for low-risk prostate cancer, there was a difference by race. Well, we looked at it, did a little bit better stats, showed that that difference by race is actually where you live in the country. We didn't see a difference in race when you start looking at counties. I looked at it in other cancers where people in the same facility with the same cancer are getting different treatments based on race, even when you take into account the area in which they live. That's a target for intervention. Right? Now I'm looking at for more advanced prostate cancer. We see places where there are more urologists. You may not be getting the best care compared to more medical oncologists or radiation oncologists. Like those are the uncomfortable truths that we have to start going after with our own data. But we just need data that is that granular.
Wow.
We need good data to do that. And there's a large lack of that.
So where can folks get a hold of you to connect and learn more and to support?
Yeah, email always, Twitter, SamWash Euro. I can put that in the chat or provide it later as well. Are good ways. And then my email is always open, samuel.washington@ucsf.edu.
Okay, wonderful. Thank you so much, Dr. Samuel Washington. Again,